Cardiac rhythms. Now, you will see cardiac rhythm questions asked on the NCLEX, and the important thing to remember is that don't get too deep in your studying for cardiac rhythms, because what you have to know about cardiac rhythms for the NCLEX is what every other new graduate nurse knows about cardiac rhythms, just like every other concept that may be tested on the NCLEX. So most of your classmates don't know anything about cardiac rhythms. So if you know some advanced concepts about cardiac rhythms and have some tools for how to interpret and understand what the question is asking, you're going to do a whole lot better than everybody else is on these questions. There's a key concept you want to think about when assessing cardiac rhythms and how it's affecting your patient. And you want to ask yourself, how does this rhythm or how does this situation affect my patient's cardiac output? Okay, so there are certain rhythms that are not favorable rhythms. It's not what we want to have for our patients. But if it doesn't affect their cardiac output, then our level of intervention isn't going to be as advanced. So, for example, you have something like AFib. We don't want our patient to be an AFib, but if you go to the mall, there's people walking around you all the time who are just chronically in AFib. And, that's okay because AFib doesn't affect cardiac output to any sort of troubling degree. Now, that's AFib. VFib, so ventricular fibrillation, does affect cardiac output, right? VFib is a lethal rhythm. Okay, you cannot live with VFib. All right, so VFib affects cardiac output because as your ventricles are contracting so frequently, they don't have enough time to refill with enough blood to squeeze out on the next beat. So it affects your cardiac output because it gets reduced cardiac output. Now you start to see levels of consciousness change because not enough blood is getting pumped to the body and to the brain. All right, so when you're thinking about these rhythms and they're asking you questions on the NCLEX about cardiac rhythms, ask yourself, how does this rhythm affect cardiac output? And from there, you can gauge your level of intervention that you feel is necessary. So there's 6 commonly tested rhythms on the NCLEX, and they may ask you a bunch of different things about these questions or come at them from different directions. So don't worry about other rhythms. Don't worry about heart blocks and studying about Winky-Bach and Mobitz blocks and bundle branch blocks and all these, sort of advanced concepts in cardiac rhythms. If this is something that you need to know as a nurse, they're going to teach it to you at your facility. So, again, I work at a big academic medical center. We have tons of specialties, and not every nurse takes courses in advanced cardiac rhythm interpretation. Only nurses that are working on a cardiac unit or on a unit with telemetry. So don't get wrapped up in this too much, but what you ought to focus on are 6 major rhythms, because these are the ones that a lot of other people know. Some of them because they're very easy to interpret and to notice, others because they are lethal rhythms and you need to be aware of them. Now, before we get into the rhythms that you need to know, let's just make sure we understand a couple different concepts about cardiac rhythms, okay, and what the different bumps and peaks and valleys and all the other little jiggly things you see on a cardiac rhythm. What do those things mean? In other words, what is going on in the heart when those things are appearing on the rhythm strip? Okay, so remember, first the atria of your heart contract, and then the ventricles. So the first thing that happens is the atria depolarize, right? So that is the P wave that you'll see on the cardiac rhythm strip. So first is the P wave, and then you have your QRS complex. And the QRS complex represents the ventricular depolarization. At the same time the ventricles are depolarizing, the atria is repolarizing. And you don't see the atrial repolarization on the cardiac rhythm strip because it just gets lost in that QRS complex. Now, the ventricles then repolarize, and there's nothing happening at the same time. So that does appear on the cardiac rhythm strip, and that's the T wave. That's the bigger bump that you'll see after that big, tall QRS complex. So there's 6 rhythms you ought to focus on in your studies for the NCLEX. The first one that you need to know about is VFib. Okay, VFib is characterized by chaotic QRS depolarization. Now VFib, the atria aren't making full contractions. They're just kind of quivering, right? The atria aren't doing anything. The ventricles are just quivering, and it shows up as this just sort of bizarre and chaotic rhythm on the strip. All right. The second one you need to know is ventricular asystole, right, or just asystole for short. Most people call it asystole, but recognize that it is ventricular asystole, and if you see that on the NCLEX, don't be alarmed by that ventricular word stuck in there. You know, that's what it is, but everybody just calls it asystole. So it's the same thing. And asystole is a lack of QRS depolarization. So in this case, the ventricles aren't contracting at all. So it's the flat line that you see. And it's not dead flat like you see in the movies. There is a little bit of waviness to it, but it's long and smooth. There's no sharp, jagged components noted to that. The third one that you need to know is VTAC, right? Ventricular tachycardia. And these are characterized by repeated and really wide and bizarre QRS segments. So the QRS segment is wide and it's repeated. It's pretty regular. So these, you're going to see rhythms, up into like the 200s in terms of beats per minute. Okay. The fourth one that you need to know is AFib, right? Atrial fibrillation. And in AFib, it's an irregular heartbeat, and you're going to see chaotic P-wave depolarization. So you're still going to have QRS complex. You're still going to have those tall spikes in the cardiac rhythm strip. Those tall spikes are going to be spaced out irregularly, but in between them, you're not going to see those normal P and T waves, right? You're going to see a bunch of little quivering in between those essentially normal-looking QRS complexes. The fifth one that you need to know is a flutter. And a flutter is often described as a sawtooth pattern. So, again, you're going to have, because it's an atrial rhythm, you're going to have your ventricles contracting as they normally do. You're still getting some cardiac output. So you're still going to see QRS complexes. You're still going to see that ventricular contractions going on. But in between are extra atrial contractions. And they have those atrial contractions have a regular appearance on the rhythm strip. So you might have 2 or 3 atrial contractions between each ventricular contraction. And the sixth thing you ought to be able to recognize is a PVC, a premature ventricular contraction. And the reason you ought to be able to recognize these is not because they're necessarily bad. They don't really affect cardiac output. People have these all the time, but you need to know this one because lots of other people know it because it's really easy to pick out on a rhythm strip. As a result, lots of people know it, which makes it an easier question on the NCLEX, and the stuff that everybody else knows, you don't get as much credit on the NCLEX for those kind of questions, right? So remember, the NCLEX is only going to ask you questions that it calculates. You have a 50% chance of getting correct, right? Because every question has a difficulty level associated with it, and those difficulty levels come from everybody else's ability on those questions. So if a low-level test taker is getting those questions correct, then those questions have a lower difficulty level. So if everybody knows it, you need to know it. All right? So PVCs are typically periodic. They might come in couplets or triplets. They might come a couple of them together. You may see a short run of them, but anything more than 6 is essentially turning into VTAC. And these PVCs are periodic, wide, bizarre QRS segments. Okay, so you have a normal rhythm strip. Everything's just going along. You got your lub-dub, lub-dub, lub-dub. Everything's going smooth, and then all of a sudden, the ventricle decides not to wait for its turn, and it jumps ahead in line, and it throws everybody else off. So imagine, you have an orchestra, and everybody's playing, and everything's smooth, and in the middle of the song, someone jumps ahead, and throws in a big bang on the drum, it's just going to make everybody bounce for a little bit, and then everybody will smooth back out. So that's essentially what's happening. The ventricle jumps its turn in line, throws everybody else off, and then everybody else kicks back into normal. So PVCs aren't really problematic. Lots of people have them all the time. I see these regularly at the hospital, and they're not problematic unless they start to affect cardiac output. Right? So remember, that's a key concept in cardiology as a nurse. And this starts to happen for a couple of different reasons. A, it starts to happen when there are more than 6 of them in a minute, or when there's more than 6 PVCs happening in a row. And when that happens, you essentially just have VTAC. Right? So a bunch of PVCs is VTAC, because in VTAC, the ventricles have basically just taken over cardiac rhythm, and the atria aren't really allowed to do their thing. They just get lost in the whole shuffle. So 6 or more PVCs in a row is often described as a short run of VTAC. And then C, PVCs are problematic when the PVC falls on the T wave of the previous beat. So that T wave, remember, is ventricular repolarization. So if the PVC falls too early and on that ventricular repolarization, it's not able to repolarize, and your cardiac output suffers. And this can throw you right into VFib. So that's called R on T phenomenon, when that PVC falls on the T wave of the previous beat. So this is an R wave that's not supposed to be there at that time, and it's falling on the T. And again, that's going to induce VFib. VFib being not good. So for these arrhythmias, you have some that are lethal and some that are potentially lethal. So in the arrhythmias box there, you got a little T thing. There's 2 lethal rhythms, okay? And then there's one that's potentially lethal. The lethal rhythms are VFib, right? So the ventricles aren't contracting at all. They're just quivering. There's no blood being pumped out of the heart. There's a lot of electrical activity going on, so you see it. And that's that chaotic QRS depolarization, but no blood's being pumped out of the heart. The second one is asystole, which is that flat line. And if the ventricles aren't contracting at all and not even quivering, there's definitely no cardiac output going on. And no cardiac output equals death all the time. That's when we start CPR or start to look at administering different drugs or shocking. Then there's one that's potentially lethal, and that one is VTAC. Right? VTAC is a potentially lethal rhythm because the heart's beating so fast, and it's just not going to be able to sustain that for a while. So after a couple minutes, that heart's going to be donezo. It's not typically a shockable rhythm if the patient still has a pulse, but if a patient goes into pulseless VTAC, that's when it's a shockable rhythm. Okay, so that's why it's potentially lethal. It's not lethal on its own for the first little bit of time, maybe a minute, 2 minutes. But if you start going into 10 minutes, your heart's not going to be able to sustain that. So that's why intervention is necessary immediately for VTAC. It's potentially lethal. So all other rhythms are non-lethal. Okay, so remember that on the NCLEX. It's not lethal unless you got VFib or asystole and VTAC that is either pulseless or sustained over a period of time. So focus on those 3, if nothing else, because everything else is non-lethal. So remember, QRS depolarization is referring to ventricular activity, right? And P waves are referring to atrial activity. Okay. So there's a couple things you need to do with arrhythmias. Right? So you have a patient who is in normal sinus rhythm all day, and then all of a sudden you get a call from telemetry, or you notice on the strip or the monitor starts giving you an alarm, and then bam, this patient's in some type of arrhythmia. Right? The first thing you want to do is assess that patient's level of consciousness. Right? So you assess LOC, and then you want to check the leads, okay? Because I can't tell you how many times something weird's been showing up on the monitor or whatever, and you go into the patient's room and one of their leads is 3/4 of the way fallen off and you're not getting appropriate conductivity. Or you get a call from telemetry that something's going on with your patient. You go and look in the room and, respiratory therapists in there doing, CPT on this patient, chest percussive therapy, and this patient's being, they're having their chest pounded on. Well, yeah, of course, it's going to show up bizarre on the telemetry strip. And the last thing you want to do then is call the code, right, when the other assessments indicate. So you go in the room and their level of consciousness is decreased. They don't know what's going on. They do feel weird. The leads are okay. Then you want to call that code. Right? But you don't want to just call a code and have the whole team show up and the patient's totally fine sitting in bed watching television, eating their lunch, and one of the leads is just jacked up on their chest. That's kind of an embarrassing moment as a nurse. Obviously, if you go in the room and the patient is unconscious, you don't really need to check the leads, right? But if the patient is conscious and you've checked the leads, then the last thing you want to do then is to call the code if the assessments indicate, right? And here's a little NCLEX test tip. You always have doctor's orders to do whatever the answer wants you to do. So don't say, well, I would choose that one, but it doesn't say I have doctor's orders. You always have orders to do anything on the NCLEX, right? It's the perfect hospital situation. You can do what you want to do based off what they're asking you, right? So what you want to do is there's 4 things you need to do in order. The first thing you want to do is hold. The second thing you want to do is assess. The third thing is call. And the fourth thing is you'll do, right? So you'll hold whatever drug has been infusing. So say it's potassium. You're going to hold that drug. Then you're going to assess the patient, assess their heart rate, assess their level of consciousness. And then you're going to call the doctor, call a code, call respiratory, call whatever is appropriate based on that situation. And then the last thing is you're going to start doing stuff based off of that phone call, based off of the protocols on your unit, based off of the doctor's standing orders or orders that they give you verbally. All right. So hold, assess, call, do. All right. So when you're taking a test on the NCLEX and the question has 4 different things that you may choose, right? One of those things is going to be a holding thing. One of them is probably going to be an assessing thing. One of them is going to be a calling thing. And one of them is going to be a doing thing. So on the NCLEX, when it asks you, what are you going to do first? The first thing you need to be doing is not calling the code. The first thing you need to be doing is holding whatever's going on, right? So stop infusing the potassium. Right? It's the first thing you should do. All right. The second thing is you need to assess that patient. All right. And assessment might be something super quick. It might just be, sir, how do you feel right now? Or it might just be you visually notice right off the bat that they are unconscious when 5 minutes ago they were not. Right. That assessment doesn't have to be a head to toe assessment. So don't call the doctor first. You want to be able to call the doctor with information. Right. So the first thing, hold. Second thing, assess. Third thing, call. Fourth thing is do. Okay. So now we have a patient with an arrhythmia and we want to treat them. Now, some of this stuff falls into ACLS or advanced cardiac life support and isn't necessarily stuff that you're going to have to know, but is super helpful because it helps give you a little more information and allow you to wrap your head around some of these concepts. Okay. So for treating arrhythmias, for PVCs and for VTAC, you want to plan to give lidocaine or amiodarone. Right? That's probably what's going to be prescribed. Right? That heart's beating so fast and so rapidly and wildly that you need to slow it down. So that lidocaine is just going to kind of numb that heart and help it slow down. For any kind of supraventricular arrhythmias, so supra meaning above and ventricular meaning referring to the ventricles. So any arrhythmias that start above the ventricles or in the atria, like A-flutter and A-fib, there's 4 different types of things that you may plan to give. There's an A, a B, a C, and a D. This helps for memorization, okay? The A stands for adenosine or adenocard. Now, for adenosine, this is that drug I'm sure you learned about in nursing school. You push as fast, okay? You push it as fast as it'll go in, less than 8 seconds. All right. Now, this is kind of a scary drug when you give it because you fully expect that patient to just go into up to 20 seconds or so of asystole. Heart just stops. So they have this AFib, and then you push this drug and they flatline on you. And then all of a sudden, bloop, bloop, it pops right back up on the rhythm, and they basically come back to life. It's kind of a scary moment. And this isn't something that you do just on your own in the room with the patient, right? This patient needs to be on a monitor. This patient needs to have the doctor present, and you need to have the crash cart present as well. All right, so you need to make sure you have all your supplies ready. You're not just pushing this drug by yourself. So A stands for adenosine or adenocard. B stands for beta blockers, which are also known as the LOLs, LOLS. So metoprolol, those are the LOLs, the beta blockers, and you can give those for AFib and A-flutter as well. The C stands for calcium channel blockers, and D stands for digoxin. Now, on the NCLEX, it might say digoxin, it might say digitalis, it might say digitoxin, or it might say lanoxin. It's not going to give you all of those, so you need to understand that all 4 of those are the same thing. Right? And remember, you're a nurse, okay? You're not a doctor. You don't have to prescribe any of these things, but you need to know what may be prescribed by the physician based off of that patient's condition, right? So if certain things indicate, they may go with one of these drugs over another. I've given all of these for patients who have AFib based off of different patient conditions. So that's it for AFib and A-flutter, right? Supraventricular arrhythmias. For VFib, you want to prepare to defib. All right. For VFib, you defib. For VFib, you defib. So for VFib, we shocked them. VFib is a shockable rhythm. Now for asystole, so there is no ventricular activity at all going on in this person's heart. You want to plan to give epinephrine. All right. So again, epinephrine this is a full-on code, right? You have ACLS protocol full operations at this point when you're going to be given epinephrine. And then the second thing you're going to give, the second drug you may give in a code situation is going to be vasopressin. But typically they're going to give a couple doses of epinephrine first before switching to something like vasopressin. They used to use atropine as a secondary go-to drug, but a lot of places are switching to vasopressin. Okay, so for asystole, plan to give epi and then vasopressin. Atropine is on its way out. So, common strips. That first strip that you see there, that's the one with the chaotic QRS depolarization. So, look, you don't see any P waves. You don't see a QRS complex that looks, typical with this regular R wave as that big spike. It's just, chaotic, right? That's VFib. The second one there, pretty much a flat line, right? You see a little waving in it, and that's what you'll probably see. You may see a little blip every now and then. That's asystole. Okay. The third one there, this is just repeated, right? You see it repeating, and it's consistent. And those are wide, bizarre QRS segments. So those repeated wide, bizarre QRS segments, that's VTAC. Now, AFib is the next one. You see basically normal-looking QRS complexes, right? But the P waves and the T waves are getting lost in all of this quivering that's going on in the atria. The ventricles are, getting all this noise from the atria, and they're basically saying, you know what, y'all aren't sending us normal beats, so we're going to take over here and we're going to start beating on our own. Now, the ventricles aren't as good at keeping rhythm because all this noise is coming down from the atria. That's why you'll see that the rate is not regular. You'll have a couple together, some pauses in between. That's why the ventricular rhythm is not regular, and you'll see all that little quivering going on in between. Right. Now, a flutter, the next one, that's that sawtooth pattern that we talked about earlier. A flutter has the sawtooth pattern. And again, you're seeing some pretty regular QRS complexes, and then in between you're having a couple kind of wacky atrial events. Okay, so there's a couple atrial beats going on for each ventricular beat. Right? Then the next one you see there is essentially you have normal sinus rhythm, and then thrown into there, you'll see there's two PVCs, right? And you see how those are kind of chaotic and wide, bizarre QRS segments. It's not a normal Q, it's not a normal R, not a normal S. There's very little T activity going on after that. So those should jump out at you. That's why everybody knows these, because they look totally different than everything else in that normal sinus rhythm. Okay. And then the very last one there, that's normal sinus. Okay. Be able to recognize normal sinus. So normal sinus, you have a P wave for every QRS complex. You have a T wave after each QRS complex. Your P waves are normal looking. Your T waves are normal, and that's normal sinus, right? It has a regular, consistent rate. So the space between the R waves, between those high spikes, are consistent. Okay, this is normal sinus. And remember, most of the time that you're seeing rhythm strips, you're looking at a 6-second rhythm. So you can take a look at that and say, okay, how many QRS complexes are there on this 6-second rhythm? Right? And so you're basically counting the big tall spikes. And then what you do is you add a 0 to that, and that's your heart rate. Okay, so you can tell if it's bradycardic, if it's tachycardic, if it's a normal heart rate, just by counting the number of QRS complexes on that 6-second strip and then adding a 0 to it. Because you have a 6-second strip, so there would be 10 of those in 60 seconds in 1 minute, right? So if you have 10 in 60 seconds, you basically just are multiplying however many you have in that 6-second strip by 10. It's a pretty fast way of assessing somebody's heart rate, especially if you're in a code situation. Just take a look down at your watch, count how many heartbeats you get in 6 seconds, and add a 0, and give you a pretty good estimate of that patient's heart rate. So that's it for cardiac rhythms, okay? Remember, don't get too wrapped up in these. Just make sure that you know what everyone else knows. And that's the 6 rhythms that we talked about. A couple of them that have some interventions that we can do. You know which ones are shockable. You are shocking 2 of them, right? VFib and VTAC if they're pulseless. So pulseless VTAC and VFib, okay? You do not shock asystole. All right, so disregard what you remember seeing from the movies where this patient's gone into a flat line, you just get that beep. That's not a shockable rhythm, okay? If they have a flat line cardiac rhythm, remember that's asystole, and we're going to give epinephrine, okay? You need to stimulate that heart to start beating again, not shocking it. Shocking it is not going to kick that thing back into beating. Shocking will reset a rhythm that's already going, but is just off of the beat, okay? The shocking just resets the beat. And that, my friends, is what you need to know about cardiac rhythms for the NCLEX.